This conference will now be recorded.
Okay, good morning, everybody. So, we'll be starting with a new chapter today. It has to do with hernias. We'll talk about the abdominal wall hernias in the next subsequent couple of lectures. Now, some common principles which are common to all kind of hernias, whether it's inguinal hernia, it's a femoral hernia, or it's a ventral hernia, incisional type, or otherwise. Some common principles need to be addressed. Now, the common sites of hernia that you usually encounter, the external hernia that we have, you can start from top to bottom and from medial to lateral. The epigastric, then you have the paraumbilical, the umbilical, then further down you got the inguinal, whole inguinal hernia equation, and then you got the external supravesical hernia. Laterally, more laterally, you got the spigelian, the incisional hernia, the lumbar hernias, more correctly displayed in this figure. So we have various kinds of ventral hernias, the types of inguinal hernias. We talk about them uh, as we go on with the lecture. And then, of course, the posterior hernias, which are not very easily visible, but they're still there. Like, for example, the sciatic hernias, the perineal hernias. The rectal prolapse is a kind of a herniation. Then you got the lumbar hernia, the superior and the inferior lumbar hernia, and of course the diaphragmatic hernia. So these are some of the hernias which are commonly referred to, which are commonly encountered when you talk about the hernias, right? Now, certain definitions need to be addressed. First of all, where does the word hernia has its derivation? So, it's been derived from a Latin word which means to rupture. That is the origin of the word hernia. And if you want to define hernia, how to define a hernia, whether it's external hernia or internal hernia, there has to be a common definition. And the common definition is an abnormal protrusion of an organ or tissue. See, organ or tissue through a defect in its surrounding wall or the first containing or enclosing layer. Why the word tissue? Like, for example, let's say the epigastric hernia, which is a protrusion of the prepetal fat. It's not an organ, it's a tissue. So it can either be an organ or it could be a tissue which is coming out through a defect in the first containing wall, whatever is surrounding that particular tissue, the proximal most layer. So that's what is surrounding wall or first containing or enclosing layer. That should be the definition of a hernia, whether it's internal or external. Now, another definition needs to be addressed, what we now understand as an abdominal core. Now, what is the abdominal core? The core basically refers to the circumferential soft tissue which is enclosing the whole of the abdominal cavity. So, superiorly you got the diaphragm, inferiorly you got the pelvic diaphragm, right? And surrounding you got the circumferential abdominal wall muscles and the flank. So, that is the abdominal core. Now, why do these definitions need to be addressed? For the simple reason that when you talk about large ventral hernias, they require to be addressed whether you want to tackle a ventral hernia or you don't want to tackle a ventral hernia. Like, for example, a patient got a double abdomen, a very huge hernia. So there the definition of abdominal core comes more important. Now, and the next is an abdominal core health. So what does it health mean? It basically involves the stability, the function, and quality of life involving the core. That means we are talking about a normal and near normal diaphragm, pelvic diaphragm, and the abdominal wall muscles and the flank. So we talk about the health of these components of the core when we talk about the abdominal core health. Then the hernia management is basically nothing but maintaining the abdominal core health, right? See how the definition is progressing. And then another definition needs to be addressed is what is the loss of abdominal domain. Now, abdominal domain basically means the domain of the abdomen. Now, when the domain of the abdomen or the abdominal core is the domain, when it gets lost, that basically means the patient's got a hernia or there has been a protrusion of the intra-abdominal contents. That would be a loss of abdominal domain. But the problem with loss of abdominal domain is that there is no agreed definition to it. Now, before we go further, just a few words about what does loss of abdominal domain mean, because this was an important point which cropped up when we were tackling very large ventral hernia. Now, the question was, if the patient's got a very large abdominal hernia, in the sense that there's almost, it looks as if the patient's got two abdomens, should that patient be tackled? Now, up to date, there is no consensus definition of loss of abdominal domain. And the best definition which is adhered to or which has been cited is a volumetric definition. That means definition which is basically dependent upon the volume of the hernial sac vis-a-vis volume of the abdominal content. So that is the volumetric definition of loss of abdominal domain. Now, if you look at the two most prevalent and accepted definitions as of now, one is the Sabga method and the other is the Tanaka method. Now, basically, if you look at this figure, it is nothing but, see, this is basically the hernial sac. So it's got a 20% volume and rest 80% still remains inside the abdomen. Okay. Now, the method, the problem is the same, but interpreting or assigning a particular method of reporting becomes different. So, in the SAPA method, the loss of domain would be 20% or more. That is the preferred method. So, it is 20%. Okay. Now, here, this talks about a domain in terms of decimal. So it's 0.25% out of 20 out of 80. That makes it 0.25. Now, which is the better method? Now, here, if you look at the total peritoneal volume, or TPV basically means total peritoneal volume. That is 100%. So if you got the hernial sac volume at 20%, that will be 20% of basically the total volume, right? Now, as opposed to Tanaka, it becomes 0.25. Now, that is 20% over 80%, that becomes 0.25. Okay, so here's 20 over 100, is 20 over 80. So that's just a method of difference in reporting. Now, even the latest discussion which came up in abdominal wall reconstruction. Now, abdominal wall reconstruction is an entirely different entity as of now. Now, that has become a very, very important entity. Why? Because there's a huge number of patients who got large metal hernias, which are not easily tackable and which are not easily manageable, and that's why the discussion becomes important. So, we have a whole separate entity known as abdominal wall reconstruction. Now, the last the last meet that they had was in 2019 in London, and see, there was no consensus even after 4 rounds of discussion. But there were some takeaways from these from this meet. Number one, the Samaga method is much easier than Tanaka. It's much easier to understand. Furthermore, loss of domain is often reported as percentage. Now, when using Tanaka, the value will surpass 100% when more than 50% abdominal pelvic volume lies outside the abdominal cavity. In contrast, the Samaga is always less than 100. Why? Because it's always reporting on a bottom line of 100, making it conceptually easier. While Tanaka says 20 over 80. Now, suppose if the volume of the hernia becomes 40, right? Let's say 60, and 40% remains inside the abdomen. So it becomes more than one, right? 60 over 40. But Samaga will always have a bottom line or denominator of 100. So that it becomes conceptually easy to understand what we are really talking about. But that even after 4 rounds, they were unable to establish a consensus regarding what. Now, what was the need for this meet? Now, we wanted, or a person or a surgeon would naturally like to know when he should not operate on a patient. That is very important. Suppose if the patient got a huge double abdomen and you try to push everything back into the pectoral cavity, what's going to happen? Abdominal compartment syndrome. The diaphragm goes up, the vessels get compressed, and the patient goes into severe hypovolemic shock, and the patient goes into severe ARDS. So you need to know when you should not tackle these patients. So there is no threshold level above which the panelists would agree on not operating on a patient. Number two, does the loss of domain predict postoperative failure? Now, I would like to know that the patient in front of me has got a loss of domain of, let's say, 30%. Now, would my operation on that patient would be having a recurrence at a later point of time? That is what is postoperative failure would mean. I would not be able to address that, because until and unless I have a severe guideline or specific guidelines which tell me that, look, over 30% do not operate. Why? The chance of killing the patient, the chance of postoperative failure. So that would be a guideline, but that guideline does not exist. Furthermore, can we have certain comorbid situations or certain variables which would help us in deciding when not to operate or when to operate? The decision to operate. Now, there are specific factors there, but still those factors need definition. So now this question becomes very, very important when we talk about mental hernia, right? So that was about the loss of abdominal domain. Now, coming back to the main topic of hernias, and if you look at the abdominal wall hernias epidemiology, now US figures are available, Indian figures are not available in one concise form. So we are talking about inguinal hernias as a major component of abdominal wall hernias to the tune of almost 65 to 75%, right? So that means almost 3/4 of these are basically inguinal hernias, right? 14% of all hernias are umbilical. 14% of all hernias are umbilical. 10% of hernias are incisional or ventral, and the female to male ratio 2 is to 1. And only 3 to 5% of hernias are femoral. The remaining, when you add these up, the remaining, which makes about less than 5%, even less than that, they are rare and they can include intraparietal. Interparietal, like for example, spigelian hernia is interparietal hernia. You could have supravesical, you could have lumbar, sciatic, perineal, and so on and so forth. Now, coming to the inguinal hernias, which form the major component of abdominal wall hernias, if you look at the inguinal hernias, we all know it's more common in the male, but how common? 8 is to 1. And if you look at the type of hernia, you will find that the indirect type is almost two-thirds and one-third are direct inguinal hernia. 3% of the hernias have a sliding component, and this is more often on the left side and more common with the indirect type. Right? We'll talk about what a sliding hernia means. Now, if you look at the side, approximately 50% would be occurring on the right side, 40% on the left side, and 10% are bilateral. That makes up 100%. Right? So there are some figures which help you in managing a patient of inguinal hernia. Okay. Now, coming to the causes of inguinal hernia. If you look at the cause of inguinal hernia, the most important cause is the anatomical, which deals with potential weak spots in the abdomen. We all know that we've got weak spots. These are anatomically weak spots, right? By development. Like, for example, you have the lumbar triangle, the superior inferior lumbar triangle, the posterior wall of the inguinal canal. Now, why the posterior inguinal canal? Because that is an area where you don't have any muscle coverage. It's only transverse fascia. At the most, you can have a aponeurosis transverse abdominis muscle at the most, and nothing in between there and the external oblique aponeurosis. So that's a potentially weak area. So similarly, you've got the whole of the Frouchard's orifice. We'll talk about what Frouchard basically means. You got a muscular defects, like for example, divarication of the recti. You got a spigelian fascia. You got wide pelvis. So these are anatomically potential weak spots where there's increased susceptibility to the formation of hernia. Then you can have a congenital cause, like for example, non-obliterated or delay in obliteration of processus vaginalis. One of the most prime example of a congenital cause of a hernia. And this is probably hormone mediated. I'm not going into the details of what is the cause of delayed processus vaginalis. We'll talk about that when we talk specifically about inguinal hernia. Now, coming to genetic causes, inguinal hernias may be hereditary, and it is usually a result of complex multifactorial inheritance pattern. And they have recently identified 4 inguinal hernia susceptibility loci. Right? They have identified them, and they have to. They are all dealing with the connective tissue homeostasis. Now, if you look at a number of collagen disorders in which inguinal hernia is very common, it is very well documented. Like, for example, the Marfan syndrome, the Earl-Danlos syndrome, osteogenesis imperfecta, congenital heart disease, aortic aneurysm. So these are instances of collagen disorders where there is weakness in the fibrous tissue. So similarly, because there is a generalized weakness in fibrous tissue, the patient may also be having a inguinal hernia. They all are concerned with the decrease in the collagen 1:3 ratio or in collagen 4. Right. Now, also calcitonin gene-related peptide have been shown to be involved in a number of patients with inguinal hernia because they are basically influencing the closure of the processes. Here, hormone mediated. So these are the important ones: calcitonin gene-related and hepatocyte growth factor affected. Now, the genetic and familial causes. If you go further, you'll find that 11, almost 10 to 11% of patients with inguinal hernia would be having a positive family history. Like, for example, a family history of carcinoma, we all know 5% of them are familial hereditary. So here also in inguinal hernia, almost 11% or 10 to 15, 10 to 11% would be having a positive family history. And what is characteristic of this family history is that it is usually clustered in families where it is most prominently the daughters are affected. It is more common. So if you look at the hereditary pattern syndrome of hernia, it is more common in the daughters or the female. And which females are affected more? Where the mother has got inguinal hernia or her sister already has inguinal hernia, which shows highest inguinal hernia formation to the tune of relative risk of almost 18 times. Almost 18 times. Or the brother is affected with inguinal hernia, there the risk is almost 3 to 4 times. But if the male child, what is the susceptibility of male child? The male child getting a hernia would be more if the brother is affected or the sister is affected, and the risk ratio is shown as here. So what we are saying is that hereditary hernias would be more common in the females and less common in the males, and that also the risk keeps on compounding itself if there is a sibling affected. If the sibling is sister, then the goes to 18%. If the sibling is brother, then it goes to 3.7%, right? What about the trauma? Trauma is again a very, very important cause for hernia, because traumatic hernia is a very well recognized entity, and usually a blunt or a sharp trauma to the abdominal wall, or a iatrogenic surgical. Like for example, most common prime example is what? Inguinal hernia, right sided, always take a history of what? Appendectomy. Why take a history of appendectomy in all patients with right sided inguinal hernia? Because appendectomy is known to injure the iliohypogastric and ilioinguinal nerves, and if they get affected or if they get damaged, then these patients will be at increased susceptibility to inguinal hernia. Right? On the left side also, urinary lithotomy. Okay, post laparotomy maximum attainable muscle strength, remember, is only 70%. So if I have my abdomen cut up, I get it stitched by the best plastic surgeon. Even then, given all these things, my abdominal wall muscles will reach strength of only 70% and never more than that, whatever the method of stitching. So that basically means I'm always at a risk of hernia formation because my muscles are weak by 30%. Pregnancy is another cause. Progesterone induced laxity of ligament. Elderly age. Why? Because collagen degeneration occurs, and that is classically seen as Malgagny's bulges in the abdominal wall. Lifestyle, a number of lifestyle, the patient is increased susceptible to inguinal hernia. Like for example, marked obesity. Now that was cited as a very important cause for hernia, but has now been disproved. A Swedish report, a very comprehensive report, says that inguinal hernia is less common in obese. Heavy lifting, they said professionals who are lifting heavy load are increasingly susceptible to hernia formation. No longer so, they are not susceptible. So these two go out of the window. Marked obesity and heavy lifting are no longer lifestyles which are increasingly susceptible for hernia formation. Coughing, straining with defecation or urination, that's why we take a history of bladder outlet obstruction. We take a history of constipation. Why? We take a history of chronic cough. Why? Chronic obstructive COPD. So these are all cases where there is an increase or increased chances that you will be having a future date hernia formation. Right? For example, peritoneal dialysis or ascites. We have seen a number of patients go to the medicine ward. You'll find a number of patients with ascites, chronic liver disease, ascites, and they start developing a umbilical hernia. They start developing a inguinal hernia. Why? Because that pressure goes on increasing, and the most weakest part of the abdomen we all know is the umbilicus. So the patient gets umbilical hernia. So these are lifestyle and diseases process. Smokers increase incidence. Why? Because the increased serum elastase and decreased alpha 1 antitrypsin levels in smokers, making them increasingly susceptible to the genesis of hernia. Clinical types, external, internal, we all know that. What about external hernia? Some clinico-pathological types or terms need to be addressed very, very importantly. Reducible, we all know that the hernia goes back in. Irreducible, we know it doesn't go back in, also known as incarcerated. So do not confuse these two terms, they are synonymous terms, irreducible or incarcerated. Now, the thing that has to be differentiated is whether with irreducibility there is obstruction or there is no obstruction. Obstructed irreducible or non-obstructed irreducible. So non-obstructed incarcerated would be in those where there is a tethering or adhesion formation between the bowel loop and the sac, right? At the apex of the sac. But if there is a blockage at the level of the neck of the sac, then that becomes a luminal compromise and obstructed incarcerated hernia. The third term we should know is what is known as a strangulated hernia. And when there is a vascular compromise of any kind, it becomes a strangulated hernia, and most commonly seen where the neck of the sac is very, very narrow. The infarcted is subsequent to strangulation. Now there is frank gangrene of the bowel. That becomes an infarcted gangrenous hernia. Inflamed hernia was the initial term, no longer used. We said inflammation of the hernia. It's not really inflammation of the hernia. It was basically the abrasion of the skin overlying the hernia or some skin condition where there's inflammation. So there's no real inflammation inside the hernia. It is basically dermatitis of any kind, whether it is irritative dermatitis, it's a chemical dermatitis, it's infective dermatitis, whatever. So it's not really inflamed hernia. If you look at the parts of the hernial sac, you have the sac with its neck, the contents, and the apex of the or the fundus of the sac. Right now, coming to some terminology based on sac contents. Enterocele, we all know we have got the bowel inside the hernial sac. Omentocele, again very easy. I've got the omentum inside my hernial sac. I have got omentocele. What is an Amyans hernia? Amyans hernia is basically when you got a inflamed appendix inside your hernial sac. If you got the Meckels inside your hernial sac, then it is a Litter's hernia. So don't confuse Litter's and Amyans. Amyans is the inflamed appendix. Now, Amyans also has got a number of subclassifications where the appendix may be inflamed, may not be inflamed. Let's not go into that detail. That's not for you to go into. Just remember, if I've got my inflamed appendix inside my hernial sac, I've got a Amyans hernia. If I've got the Meckels inside my hernial sac, I've got a Litter's hernia. Right? These are easy to understand. So we are just dealing with content. Now, what is more important, much more sinister, is a Richter's hernia. Why? Richter's hernia. See this. This is a Richter's hernia. Now, what's happening out here? See, only part of the bowel wall has herniated. That means the lumen is still continuous, and that's why the diagnosis of this condition becomes late. Gangrene occurs out here, and then that leads to peritonitis. So, diagnosing a Richter's hernia where there is entrapment only a part of the intestinal wall with partial luminal narrowing becomes very, very difficult. Similarly, much more important and much more complicated is what is known as a W hernia or a Madel's hernia. Now, Madel's hernia is basically a W-shaped hernia. Why W? See this figure. There's the afferent loop, afferent, AFF, into the sac, goes back inside the abdomen, comes back into the sac, goes back inside the abdomen. So what's happening? What's happening is that similarly out here, see, that's what's happening. Into the sac, into the abdomen, into the sac, into the abdomen. So that becomes the efferent loop, that becomes the, sorry, this becomes the afferent loop that's dilated, and this becomes the efferent loop. The afferent loop and the efferent loop. Now, what you do is when you're doing a hernial operation, you look at this, you release the sac constriction, and you find the bowel turns normal. You're very happy, push everything back inside, close the abdomen. What have you forgotten to inspect? You've forgotten to inspect this bowel. This bowel you have forgotten to inspect. That is a very important part. And that is the reason. That's the reason why Madel's hernia has a number of complications because of incomplete exploration. You have not bothered to explore this part of the bowel. So remember, whenever you're exploring a complicated hernia in terms of obstructed or strangulated, remember, draw everything out until you have only one bowel loop coming out and one bowel loop going in. Now, here what is happening? There are four loops. See, not loops, four segments. One coming, one going, one coming, one going. So there are two loops here. For a proper exploration, you should have drawn everything out until you have one single loop out here with one afferent and one efferent. Is that clear? So remember, whenever you have a complicated hernia, be on the lookout for Madel's hernia. Draw everything out until you've got one afferent and one efferent, and before that, please do not close the abdomen. Then a pantaloon hernia. Pantaloon hernia, also known as a rhombus hernia or a saddle hernia. You know what a saddle is? Saddle is basically on a horse or a mule, wherever you apply it. So you got one leg on one side of the horse, the other leg on the other side of the horse. Similarly, pantaloon is saddling the inferior epigastric artery. Now see this figure. See, this is the interlingual hernia. This is the inferior epigastric artery coming out here. So one hernia on one side of the inferior epigastric artery, the other on the other side. So this is the direct component and this is the indirect component. So you're straddling the inferior epigastric artery and you got both a direct and an indirect hernia, and that's why you call it a pantaloon hernia. Then come to sliding hernia, which is always hernia engaged. Now that is important. Why? Because if you try to deal with this hernia like a simple hernia, you are in for trouble. Now see, can you see this is the hernial sac? Now this is the peritoneum, and you dissect it out and you start tying this here, and then you push everything back. What have we done? See, one part of the wall is being made by the bowel. You'll tie the bowel in this patient. You will try dealing with the sac just like a sac of an ordinary hernia. And that is why this has to be dealt separately. Usually indirect hernias have got the sliding component, more common on the left side where the whole of the sigmoid colon comes in, on the right side the cecum comes in, right? So you have to make this intraperitoneal. Before you do this, you have to make this intraperitoneal, or you do not open the sac at all. Do not open the sac at all, just push it in. Please do not try to ligate the sac in a patient of sliding hernia. If you're going to ligate the sac sliding hernia, you're going to ligate the bowel, and you can understand what's going to happen if you push your ligated bowel back inside. You can well imagine what's going to happen. So remember, understanding and recognizing sliding hernia is also very important. So these are some of the terminologies very commonly used, and you have to remember them. There's no excuse for not remembering these terminologies, right? Right from ventrocele down to sliding hernias. Now coming to the diagnosis of hernia. For the most part, the diagnosis of hernia is almost always clinical. Imaging studies are not usually required unless until in the normal workup, unless until you got a specific scenario where you like to go in for imaging study. Like for example, ultrasound may be required when you have to differentially diagnose a mass in the groin or abdominal wall from a hernia, right? In differential testicular sources of swelling. But most important use of ultrasonography is in the postoperative period of management of hernia, where you have to differentiate between a recurrence of a hernia and a seroma which has occurred in a hernial sac. Right? Is a plain scagogram required? May be required in those patients who have got an incarcerated, obstructed, or strangulated, where you're looking for acute obstruction. Is a non-contrast CT required? Non-contrast CT of the abdominal pelvis may be required, or a CCT with oral intravenous contrast may be required in certain patients of hernia. Now, a plain non-contrast usually is done in patients with ventral hernias where you want to classify the ventral hernia. Now, classification involves what? The size of the defect. Number two, the number of defects and the contents of defects and whether there is any adhesion there or not. So it's very important. A CT is a very, very important part, or a high resolution ultrasonography is a very important part of assessment of the defects in a ventral hernia. Not so in inguinal hernia, but a ventral hernia, yes, almost always. And then, of course, the other use of a non-contrast CT would be in trying to rule out other abdominal pathology, like, for example, ascites, portal hypertension, and malignancy. What about a CCT or contrast enhanced CT? Usually with the oral IV contrast, usually required where you want to have early detection of hernia. I have a mild pain in the inguinal region. My doctor examined me. He said, you may or may not be having hernia. It's not visible. That bulge is not visible. What do? I go in for a CT, a contrast CT, and with the Valsalva maneuver, I can see that there is a bulge beyond the confines of the abdominal wall. So, diagnosis of an intraparietal hernia, not visible externally. Again, a very important component would be a CECT examination or a CECT investigation to decide upon the spigelian, obturator, and interparietal hernia. And in those patients where the body habitus, like for example, a very, very obese person, where the bulge is not easily visible, that becomes very difficult for the physician to perform a very good physical examination. He may have to resort to a contrast and a CT examination. Herniography. Herniography is nothing but visualization of the hernial sac by injecting a radio contrast to the peritoneal cavity. And it defines most hidden hernias, like for example, small bubnoceles, interparietal, similar to what we are looking at in CT, similar to what we are looking there. Herniography also defines the same thing. Poorly palpable or luminal contrast is very important to be injected in the correct plane. It may give rise to infection. If, like for example, if you inject the contrast into you manage to puncture the bowel, then the chances are that you're going to have a peritonitis in the postoperative period. So that's just a part of the complication of a herniography. MRI, a very important investigation in those patients where the patient is presented with a groin pain. Remember one thing, this is a very, very important problem, very, very common problem in the young age group between 20 to 40 years in sportsmen. The patient comes to you with a pain in the groin. You examine the patient, you find there's a hernia. Immediately, your answer is, look, you got the hernia. This is causing a pain. Get yourself operated. The problem arises only subsequently. You operate on this patient. The hernia disappears. Patient keeps coming back to you. Look, my pain is still there. So what has happened? you have misinterpreted that hernia to be the cause of his pain. While all the time, because of heavy manual activity or sportsman activity, whatever he was doing, has led to a number of other problems, or could be another problem. Example, ligamentous, myogenic, or orthopedic injuries in that patient. So remember, in the 20 to 40 years of age group or heavy manual workers or sportsmen, be careful before assigning the hernia to be the cause of the pain in the patient who's presenting to you. That's very, very important. And that's why in that age group, you have to be on a guard. And if there's even the slightest suspicion, go in for a proper investigation, MRI. Right? Laparoscopy is it heavily required? Yes, it is required in a major way in patients with ventral hernia. Why? Because I want to look at adhesions, the number of adhesions there, the conditions of bowel and intercostal strangulated hernia. Inguinal hernia, where there is a contralateral occult hernia or not. So these are some of the instances where a laparoscopy may be required for diagnosing a hernia. Treatment principles and options. Do all hernias require intervention? About 5 to 10 years back, there was a new thought process in hernia management that all hernias do not require surgery. There should be a case made for watchful waiting. Now, see, now questionable. This was then. Now, what has happened when they have a number of studies to back them up? They say that watchful waiting leads to more complications rather than operating on these patients. So, watchful waiting has now been relegated to a very, very small group of patients. In which patient? Very old patients with very small, easily reducible or direct hernias and which are asymptomatic. That is the only group where watchful waiting is now advocated. Otherwise, it's no longer advocated. Every hernia should be absolute to be operated. Absolute immediate indication is all symptomatic, irreducible or strangulated, a hernia which is increasing in size, a patient, young patient, and large hernias. They all have to be operated, whether they are symptomatic or they are asymptomatic. What are the options available? You can go in for open or laparoscopic approach. You got a herniatomy, which basically is a term which means opening. Otomy, whenever we say, means opening and closure. Ectomy means excision. We all know that, right? So herniatomy is the term where you open, but conventionally is used for all ectomies. So the correct term, when you excise the sac, we used to call it herniatomy, or we still call it herniatomy, where the correct term should be herniectomy, it should not be herniatomy. Anyway, so herniatomy basically would mean opening the sac, looking at the contents, inspecting the content, especially in obstructed hernias where the bowel is gangrene or not, and then dealing with whatever method you deem fit and pushing back everything in and closing the sac. Herniatomy. If you excise the sac, herniectomy. Herniorrhaphy basically means a repair process, right? And then you got hernioplasty. Now, while on this topic of herniorrhaphy and hernioplasty, it is very, very important. What is the difference? Now, the difference is not the mesh. Remember, it's not the mesh. Raphy means approximation, plasty means bridging. Never forget this, underline it. Whosoever are in the class now, uh, please underline it. Herniorrhaphy means you're bridging, you're approximating the defect. Now, approximating means what? Approximating the edges of the defect. So you're going to approximate the edges of the defect. While if you try to bridge it, whether it's a mesh or something else, whatever, it can even be fascia, right? Or it could be a darned silk wire, or it could be skin, whatever. So, with whatever you're trying to bridge that defect, it would be known as hernioplasty. It's a different matter that the most common method of doing a bridging is mesh. That's why it's more becomes synonymous with a mesh hernioplasty. Okay, so Rafi means approximation, plasty means bridging. Never forget this. Now, anatomy of the anti-abdominal wall requires assessment. Why? Because mainly in abdominal wall hernias, you got a ventral hernia, you got a inguinal hernia. You have to understand that. I'm not going to go into the details of the abdominal wall muscles. We all know the external oblique, the internal oblique, the transverse abdominis, and the serratus anterior. In the cranial part, that's the lower part of the subcostal area. The pectoralis major also important. Why? Because it is attached to the lower six ribs, and that becomes very important. But the more important, of course, is also the central muscle, and that's the segmented muscle or the rectus abdominis muscle. Right now, the reason why rectus abdominis is important is because it has got a number of intersections to it, and that intersection is these tendon intersections, they are subdividing the muscle into different muscle bellies. So each of them, when they contract in coordination, they would lead to the prime effect of rectus abdominis. If suppose these intersections were not there, this would have become a long muscle. In contracting, it would have a bowstring effect, and that bowstring effect would negate its beneficial effect. So remember, the reason why the intersections are there, any long muscle, when it contracts, would contract like a bow. It will contract like a bow. The single, say one origin, one insertion, contraction, it would cave in like a concavity. But if you got different intersections, like here, each of them going to contract separately, so it's not going to have a bowstring effect. It will give the desired strengthening effect, right? So 6 to 8 smaller muscle bellies are there, and they contract individually, progressively, resulting in graded increasing flexion of the torso. That's one. Number two, the second thing you need to know about the rectus abdominis muscle is that the difference or the distance between the two opposite bellies, what is known as the linea alba. Now, when should you call it excessive disparity or excessive separation between the two linea alba? When you have a gap of 2.7 centimeters or more, then it is known as divarication of recti. So remember this definition: divarication of recti needs defining that the distance between the medial edges of the two rectus abdominis, that means the right and the left, the distance between the medial edges has to be more than 2.7 centimeter, right? And the function of the rectus abdominis muscle, we all remember from a knowledge of anatomy: tensing the abdominal wall, flexing the trunk, stabilizing the pelvis, and as an aid in childbirth, defecation, micturition, and forced expiration, all normal physiological or abnormal physiological functions, right? The rectus sheath is also very important, very, very important part of hernia management when we talk about laparoscopic hernia management of inguinal hernias, or when we talk about laparoscopic hernia management of ventral hernia. Now it has become increasingly important, and we have to remember that above the arcuate line, it has got both the posterior sheath and the anterior sheath, and the anterior posterior sheath, external oblique, internal and transverse abdominis, and internal oblique sending an anterior division and a posterior division, right? Below this, the yellow is the transalus fascia. When you come to the level of the arcuate line and below, we know that all the three aponeuroses go anteriorly. They go all anteriorly. Just below the arcuate line, they all go anteriorly, and the posterior sheath is missing. And that's why below the arcuate line, you got a potential weak area. And that's why I remember that when we say that midline incisions infraumbilical are increasingly susceptible for ventral hernia formation, that's the reason. There is no posterior sheath. And that's why it is advisable that if you have to give an incision in the infraumbilical area, prefer not to give a midline incision, prefer giving a paramedial incision. Right? One of the reasons why those are increasingly susceptible to the formation of ventral hernia because of the absent posterior sheath. The other thing we need to know about the rectus sheath is the lateral edge, which defines what we know as the spigelian line or the semilunar line, extending in a curved fashion from the ninth costal cartilage to the pubic tubercle. See, that's the line. It's a curved line, which is concave medially, convex outwardly, right? And this line denotes the lateral fusion. What does it denote? See this. This is the line. What is it denoting? It is denoting the lateral fusion of the layers of rectus sheath. That means the anterior and posterior rectus sheath are fusing here. That denotes the semilunar line. It can also be said that it denotes what? It denotes the transitional transverse abdominis muscle towards aponeurotic tendon. If you look here, see, aponeurotic tendon. So this was here. As it goes down, this becomes the area of the semilunar line. That's the semilunar line for you, right? So the lateral, the medial edge of the external oblique and the internal oblique, or it could be the transition transverse muscle towards aponeurotic tendon. The spigelian fascia is a fascia. Look at this fascia. See the white? That's spigelian fascia for you. Now this is the fascia between the semilunar line and the lateral edge of the rectus muscle. So if you look at, see, this is the lateral edge of the muscle and the spigelian line. So there is some gap here. That is a spigelian fascia for you, right? So it is extending between. So we now know the lateral medial extension. What about the cranial and caudal extension? Usually around the umbilicus and down from the umbilicus is the area of the spigelian fascia, and that denotes the spigelian belt. What is the spigelian belt? This is 5 to 6 centimeters from below the umbilicus. That's the spigelian belt. Why is it known and why is it important? For the simple reason that this is an area which is increasingly susceptible, and 99% of spigelian hernias occur in this area of the spigelian belt. Most common site for spigelian hernia, and the problem with spigelian hernia is because it's an interparietal hernia. Until it's very very large, it tends to get missed very easily, right? So the applied anatomy about the rectus sheath, apart from the spigelian fascia and the spigelian belt, the other thing is when you have a rectus sheath hematoma, it is usually very easily goes pre-peritoneally. Very easy expansion. Why? Because below the arcuate line, look, there is no posterior rectus sheath, so that the trickle of blood can easily go in and lodge itself in the pre-peritoneal area. So it goes with relative ease inferior to the arcuate line since the sheath is absent. So rectus sheath hematomas always tend to gravitate downwards, right? A rectus sheath block is a block where local anesthetic is injected in the plane between the sheath and the rectus muscle, gives a very good midline anesthesia or analgesia, and usually in the postoperative period for midline incisions. But a better method of analgesia would be giving it further more laterally, what is known as transverse abdominis block. I've just mentioned it because that becomes a comparative block to rectus sheath block. It is not given in the anteabdominal wall, it is given posteriorly in the posterior lumbar triangle, and it gives a broader area than a rectus sheath block, because rectus sheath block is going to give a block only in the part of the rectus sheath. The lateral part beyond the rectus sheath, that means the lateral edge of the rectus sheath, will not be anesthetized or there will be no analgesia there. But if you give a transabdominal block, the analgesia would be there. Vectors of forces in the abdominal wall, we have to understand, because that forms an important part of ventral hernia. And the thing which I'd like to point out is this is the Pascal's law. This is a closed abdominal wall, and whenever you got an increase in the tension or increased pressure inside the peritoneal cavity, is going to be equally transmitted on all parts of the wall. And if there's any defect in any particular area, is going to bulge out from there, right? So the forces acting in the linea alba and equally in the rest abdomen is showing increased propensity in the weak areas. And the weakest area, remember, is the umbilicus. Point number one. Point number two, forces in transverse direction reportedly twice as much as forces in longitudinal direction. So if you got a longitudinal force and you got a transverse force, so this separating force would be primary cause for leading to separation rectus abdominis, and these forces would be twice as much as forces in the vertical, right? Because most of these muscles, see, the external oblique is obliquely acting, the internal oblique again obliquely acting, right? Transverse is directly transverse. So if you look at these three together, the net result is a transverse resultant force acting on the midline, right? The vertical force or the longitudinal force is not the prime reason for hernia formation. That's why contraction of rectus muscle does not promote hernia formation. Does not. This would promote hernia formation. Okay. The blood supply, if you look at the blood supply, the musculophrenic and the superior epigastric coming from above, see, they're all part of the internal thoracic, the terminal branches, and from below you got the inferior epigastric artery, right? And along with that, branches directly from the femoral. Superficially, you got the three: the superficial, circumflex iliac, the epigastric, and you got the external pudendal somewhere here, and you got the deep circumflex artery, which is the direct branch of the external iliac artery. More for that in the subsequent slide. So from below and above, you got a very good blood supply, both supplying the superficial part of the abdominal wall and the deeper part of the abdominal wall. Similarly, for the rectus abdominis, you got the intercostal perforators covering the abdominal wall. You got the epigastric perforators from the superior epigastric, inferior epigastric. So they're all supplying the abdominal wall. So we look at the superficial arteries from above. The intercostals are there, and along with that, the subcostal, the lumbar arteries are there coming from behind, and you got the two important epigastric and the lateral part, which is basically the thoracolumbar. Below, you got the superficial epigastric, and we already talked about the pudendal and the perforators from the inferior artery. If you look at the deep arterial supply, the anastomosis occurring in the rectus sheath between the supraepigastric and the inferior epigastric artery, which are the two important arteries, and the inferior epigastric artery always descends up behind the rectus abdominis muscle, hugging the posterior surface in between the sheath and the posterior surface of the rectus abdominis muscle. And the anastomosis occur somewhere in between, right? The deep circumflex artery, which is again supplying the deep part of the abdominal muscle, is a direct branch from the external iliac. See, this is the deep circumflex artery, which got ascending and a transverse branch, and that ascending branch makes contact with the thoracolumbar. The blood supply is rectus abdominis. If you look at this figure, you'll be able to see the blood supply coming out here, the inferior epigastric. See, I told you hugging the undersurface of the rectus abdominis, hugging the surface, right? And it's very, very important that you have to see where the vessels are lying. I'll tell you in the later slides why that becomes important. So, if you're looking at the rectus abdominis, blood supply from above, the superior epigastric, from below, the inferior epigastric, and numerous small segmental contributions. If you look at this figure again, see here, inferior epigastric, superior epigastric, superior, inferior, and a number of perforators and small supplies from inside. But these two form the major part of the rectus abdominis supply. Okay. Now the veins are again the deep inferior epigastric vein and superior epigastric vein, and we all know the rectusial veins, which are veins during the rectus muscle. That's why the name rectusial veins, and they all have a communication with the inferior epigastric. That's the inferior epigastric. These are rectusial. See the rectusial 1, 2, 3 branches, and they're communicating with what? The rectusio-epigastric communicating vein, right? And below the iliopubic vein. And this communication together forms what is known as the Vanderbilt circle, which we'll talk about when we talk about the details of the laparoscopic anatomy of inguinal hernia. So that forms the Vanderbilt circle in the space of Bogrov's. The nerve supply comes from thoraco-abdominal nerves right from T7 to T11, and they pierce the posterior layer of the rectus sheath. Why this is important? We'll tell you in the subsequent slides, right? The venous drainage again is to the superficial system. Again, the veins representing the superficial epigastric and the inferior epigastric veins. In the region of the inguinal region, you got the three veins opening into the saphenous. Remember the terminal tributaries of saphenous. I hope you all of you remember that. The circumflex iliac, the superficial epigastric, and the external pudendal. So these are the three important veins which are supplying the lower part of the abdomen, draining into directly into the great saphenous vein, and they're all draining the lower part of the abdomen, right? A few parambilical veins join the portal system, and that's why you have what is known as the caput medusae. They're superficial veins which are in communication with the portal system to the ligamentum teres, and they get dilated when they got a increased portosystemic circulation or opening up of these channels, right? The skin of the lateral part of the abdomen gets drained through the intercostal, lumbar, and deep circumflex iliac veins, right? Now coming to the superficial epigastric, I think we'll skip this. But coming to the deep venous system, we look at this external iliac. See the external femoral, external iliac here, and this is the circumflex iliac coming and the inferior epigastric vessel. So upper supraumbilical part, you got two large veins, the superior epigastric and musculophrenic, the terminal tributaries and thoracic, and below, and of course the intercostal, subcostal, lumbar veins, and below you got two large veins from below the inferior epigastric and the deep circumflex iliac, the two important veins. You can see the two important veins coming out here, the circumflex iliac and the inferior epigastric, right? And both of them, they are communicating with the superior and they communicating with the superficial. So this is a superficial inferior epigastric, the deep inferior epigastric. See this communication. That's a very, very important part of the communication. And these are the perforators that are there. And this perforator is a walled perforator which is directing flow from the superficial to the deep as also in the lower limbs, right? Now coming to the lateral abdominal wall, it is mainly into the axillary vein, and infraumbilical part drains into the femoral vein. Umbilical area is a watershed area. That's why it's known as the watershed area. Why watershed? Because venous blood and lymphatic fluid drain upward above the plane of the umbilicus and flow downwards below this plane. So remember the term umbilical area, the venous drainage above subumbilical goes axillary, infraumbilicus goes towards the femoral and to the great saphenous. Okay, both the venous and the lymphatic. So that is why the umbilical area is known as the watershed area. The neurovasculature is very important. Why? When we talk about the repair and incisional hernias, the neurovascular becomes vasculature becomes very, very important. And remember the new vessel supply of external oblique and enters from the lateral end. Now, this is very, very important. The plane between the external oblique and internal oblique is completely avascular and can be dissected with great ease. Why is this important? Because of a relatively newer procedure, or I wouldn't say a newer procedure, but a procedure which has come into fore about 20 years back, which is known as the component separation technique. CST, component separation technique. Anterior basically means you are sliding the external oblique over the internal oblique. So if there were vessels between anterior external oblique and internal oblique, would you be able to separate the two muscles? No, you're going to damage these vessels. But because that plane is avascular, the external oblique can easily be slided or can be dissected away from the internal oblique. Point number one. Can the same be said for between the internal oblique and transverse abdominis? No. A big no. Why? Because all the vessels and the nerves are running in between the internal oblique and transverse abdominis. Right? That is why this plane should never be dissected. Never dissected. Never dissect in between the transverse abdominis and internal oblique. You can easily dissect between the external oblique and internal oblique. Is that clear? Ilioinguinal, iliohypogastric nerves. This is a very, very good figure. It tells you rising from the lumbar plexus and how it ultimately reaches the inguinal canal, traversing from the quadratus lumborum, then lying at transverse abdominis, then puncturing. See these muscles. Can you see these muscles? One, two, three. Abdominis puncture there. Then it punctures the internal oblique in the region of antesuppalex spine. That's the antesuppalex spine, and becomes superficial in the inguinal canal. It's lying over the internal oblique, and then it punctures the internal oblique and goes over the external oblique. So that is how it proceeds. These two are important. That how it proceeds. Now, this is where it comes, the crux of the problem arises. Now, if you look at these nerves, can you see these nerves that we already talked about? The linea seminillaris is there, and then you got these nerves entering into the rectus sheath. See the nerves entering out here. Okay. Now, what are we trying to show in this figure? This is the arcuate line, the rectus muscle, and this is the area where the segmental nerves are entering. Now, I am doing what is known as a transverse abdominis release operation, which is now a very accepted operation for a ventral hernia. Now, what do I need to remember? What I need to remember is that I should not be cutting in the area where the nerves are lying. Suppose if I make a cut here, what am I going to do? I'm going to damage everything. The nerves are entering rectus abdominis where? Here. So if I cut more medially, see this is a more medial cutting, and then enter the fascia transalis and transabdominal muscle, that would be a better method of doing. That's why this is a modified tar incision where the muscle that the transabdominis is shifted up, and we go more medially and then approach the fascia transalis. So what is to be remembered is that my incision should not be cutting these nerves. And the only method of preventing cutting these nerves is that making an incision in the posterior rectus sheath more medially so that I do not cut the nerves which are entering the rectus abdominis muscles. See, can you see transabdominis, internal oblique? I told you the vessels are lying in between TA and IO. If they're lying in between and then entering here, and if I give a cut here, I'm going to cut this here. Suppose if I try to make an incision here, what am I going to do? I am going to cut. If I make an incision here, I am preventing injury to the vessel and I am preventing injury to the nerves. And from here, I straight away enter. I make an incision posterior to sheath and I straight away enter into the spleen. If I cut here and then enter, I'll be damaging the vessel, I'll be damaging the nerve. Similarly, if I cut here, I'll damage the vessel and the nerves. If I cut here, I would not be doing it. Is that clear? So that is why the entry point of these vessels or neurovascular bundle becomes important, right? In the midline, the adjacent to the paramedian region, the periumbilical perforator network is very, very important. And that is why I see this periumbilical perforator. Now, if I make an incision here, this is a midline incision. And when I make a midline incision, when I close, I try to mobilize the skin flaps. Now, suppose if I'm going to mobilize the skin flaps from here to here, what am I going to do? I'm going to cut these rectus perforator. So remember that when I'm going to give this incision, the skin undermining in the periumbilical region should be kept to a minimum for a fear of devascularization of these flaps. So please do not undermine the skin too much in the periumbilical area. or these perforators would be damaged. Is that clear? Another very important point in paramedian incision is this is the rectus abdominis. These are, see this nerve coming from in between internal oblique and the external and the transabdominis ending rectus muscle. This is the rectus muscle. Now, when I'm giving a paramedian incision, either I give an incision which is muscle splitting, I split the rectus abdominal muscle, or muscle retraction. Which would be better? Now, if I'm giving a muscle splitting, this part of the muscle would be denervated. Very easy to understand. See these nerves coming here? When I'm going to cut this muscle, I'm going to cut the nerves. That means the medial part of the rectus abdominis would be denervated, becomes flaccid and useless. So ultimately, your repair would be weak. Why? Because this part of the rectus muscle has been completely has undergone atrophy. While if I just retract this rectus abdominis and then give an incision and just cut the anterior sheath and the posterior sheath, that would be better method. That is why rectus retraction paramedian incision is a better method than giving a muscle splitting incision. What does this figure show? I give a two lateral. Now, in those patients where I want to give what are known as holding sutures or retention sutures, where the abdomen closure is very difficult, you may not be able to understand this very explicitly at this point of time. But just remember that when you got a very tense abdomen, we have to stitch it. That is stitch it. So what do? We apply two layers of sutures. One, I have closed the skin, but I fear that it's going to open up, so I give what is known as retention suture. If I give a retention suture very far laterally in the region semilunar line, this is a semilunar line, what's going to happen? See these blood vessels? Now, when I tie this suture from here and the other suture from here and tie it in the midline, what's going to happen? I'm going to constrict these vessels. And if I constrict these vessels, my whole rectus abdominis undergoes atrophy. So remember, your retention suture should never extend to the semilunar line, should never reach the semilunar line for fear of damage of these blood vessels, right? And the blood supply now, because we are making flaps, we have divided the blood supply to the abdominal wall in a number of zones. There are a number of methods divided into zones, but here we just stick to one, and that is the Huger's method of zonal classification of vascular supply. And you got zone 1, 2, and 3. Zone 1 is basically the deep epigastric arteries. That is zone 1. Zone 2 is the four main arterial system. Now this has got the most important. See these two vessels out here, and the lateral or zone 3 is basically an area which is the most lateral cranial aspect of the abdominal wall. This is the lateral cranial aspect, right? This whole thing is zone 2. This is zone 1. So zone 1 is only the superficial epigastric, the superior epigastric artery. Zone 2 is all inferior epigastric arteries and the four main arterial systems. And zone 3 are the lateral most. And the applied anatomy is usually when we try to make these musculocutaneous flaps in repair of abdominal wall defects, and that is where it becomes important, right? The functions of the abdominal wall. Is it functionless? No. Now we understand the function, and that's why what is becoming more important is what is known as IPOM repair. And what is the IPOM repair? IPOM repair basically is trying to close the defect. Now, when we were doing a repair of the ventral defects or ventral hernias or incisional hernias, we just used to apply a mesh hernioplasty. That's the end of it. Did we do anything for the surrounding defect? No. It was left as such. But now once we understand that a proper muscle is required for the physiology, now we understand the abdominal function. So we are understanding that the muscles of the abdominal wall, they are forming the abdominal core. Posture maintenance is dependent on them. Almost the spine is basically dependent or helped on by the abdominal muscles, and they have got a very important role in essential physiological body functions because of their dynamic nature of distensibility and contractibility. They can contract, they can distend. That's why post meal, what do you have? You have the feeling of bloating. What is bloating? That is basically, of course, the gas there, but the abdominal muscle wall relaxes. It bloats up, right? So urinating, you have to apply pressure over the abdomen, not by your hand. It's involuntary. So defecation, urinating, coughing, sneezing, vomiting, childbirth, etc. They are all important areas of important physiological functions where the abdominal muscle has got a very, very important role to play, right? So now we know the function of the abdominal wall. I think we'll finish here and we'll start the groin hernias next time. Thank you for your time. If you have any questions, you can always get back to me. Thank you.